I must say that we are privileged to have Professor McMurray in this session, who is the credited to introduce this therapy. Is it audible now? Yeah. So, we are privileged to have Professor McMurray in the session today, who is credited to have introduced this therapy in heart failure. He was the principal investigator for the Paradigm heart failure trial. I think, sir, if I make any mistake, you will excuse me. I think when we look at the spectrum for heart failure in the ARNI, like acute heart failure with reduced ejection fraction, acute decompensated heart failure issue, heart failure with preserved ejection fraction, and also in severe kidney disease and heart failure spectrum. So I think there are few we have now. They'll share with you the data that we have. Of course, I think this neurohumoral mechanism for heart failure and how to handle, we knew for last, I think, 20 years plus that RAS inhibition and beta blocker, neural sympathetic system inhibition help patients with heart failure. But the other arm, the neuropeptides augmentation, that may help, has been also a sort of interest in that how we can use this particular mechanism also to improve patient with heart failure. And I think this has been area of investigation for a long time. And initially was that how we can inhibit neprilysin so that we can augment the neuropeptides which are beneficial to the heart. I think because they were ineffective due to angiotensin inactivation, and then it was like neprilysin. I think there's a lot of noise. There was a neprilysin inhibition plus A inhibition, omaveloxolone, which came. But because of the angioedema issues, I think this drug did not catch that favor. It's only then probably neprilysin inhibition, angiotensin receptor blockade became that this probably be the ideal molecule to address to this particular arm of the sort of heart failure you want to improve. So this was a sort of basis that sacubitril, which is neprilysin inhibition, and there's active element, and then the neuropeptides increase, which have a beneficial effect, like they lower blood pressure, they reduce fibrosis, decrease aldosterone. So these, thank you. These, I think, mechanism are the way that we are able to sort of help these patients. This was the first landmark trial. I think we have Professor McMurray here. This was in, I think it presented in Europe Congress 2014 September. And that was the landmark that this molecule has shown a significant benefit as compared to enalapril, which is, we knew from the consensus study that has a significant survival benefit. I think soon it was approved by the FDA. It was introduced with the name of Entresto in USA, Europe, and then soon was available to us as Bimeda. And this study significantly has shown that there's a benefit in mortality, all-cause mortality, cardiovascular disease mortality, sudden cardiac death issue, worsening heart failure. So I think that in all parameters it showed that a significant benefit of this particular molecule as compared to enalapril, which we sort of had known for some years. So there was a 20% reduction in the cardiovascular death or heart failure hospitalizations, and 20% reduction in cardiovascular mortality, around same in heart failure hospitalizations, and secondary endpoint also shows significant benefit without any kind of any adverse issues. I think this is mainly on that basis that now even today the 2022 ACC, AHA and Heart Failure Association recommendation shows that ARNI is the class 1 A recommendation for patient with heart failure, both ACE inhibitor or ARB to be used only if it is not feasible to use ARNI. And then If a patient who are on ACE inhibitor or ARP and tolerating very well, they should be replaced with ARNI because it has a much better benefit as compared to those agents. Of course, we also will sort of be aware that ARNI should not be administered concomitantly with the ACE inhibitor or within 36 hours of the last dose of the ACE inhibitor. And if there's any patient of angioedema issue, I think we should avoid. Then the second spectrum was the acute decompensated or advanced heart failure, because paradigm heart failure used only patients who were stable heart failure, class 2 to 3. In these kind of patients, we know that they repeatedly get to the hospital, they have a high mortality in the first 30 days or so. And so this was that how this particular agent sort of, in these kind of group of patients, how the ARNI behaves. And this was the pioneer heart failure study, which was published in 2018. The entry criteria was that heart failure, advanced heart failure, low ejection fraction, the last 6 months, elevated biomarkers, and the patient initially stabilized during hospitalization. Like the blood pressure was 100 plus, and no symptomatic hypertension in the last 6 hours or so, and no increase in IB diuretics in the last 6 hours or so, and no IB anatros for the last 24 hours. So this kind of a patient then were initiated with ARNI, and again compared with enalapril, and the study period was 8 weeks, mainly to evaluate biomarkers, surrogate efficacy, evaluate safety and tolerability of this, and explore the clinical outcomes. What was, this is the 400 plus patients, comparable, and all the patients had a blood pressure which was stable around 100 plus. And nearly 50% of the patients were on ACE inhibitor or ARB therapy, and more than 50, around 60% possible on the beta blocker. So they were tolerating these drugs, and blood pressure was stable, and during that time, I think they were initiated with this particular agent. And what was seen, that in the 8-week period, if you look at the anti-proBNP decrease fall, there is significant benefit or fall in anti-proBNP with ARNI as compared to enalapril, which showed that this probably will have a very salutary or good effect even in these patients. I think this was looking at the adverse effect. I think there was no worsening of like any renal function disturbance, hyperkalemia, angioedema. They were, I think, similar to what in enalapril. The secondary outcomes like the death, rehospitalizations, I think they also, like composite of death, heart failure, rehospitalization, LVAD, or listing for transplant, again, there was a significant difference between ARNI as compared to the enalapril. So I think this drug shows that even in advanced heart failure, when you stabilize them, before you discharge them, I think they should have the benefit of this introduction of this particular drug. Even rehospitalization in these patients were also much less as compared to enalapril. I think the only thing, the limitation, if we look at pioneer study, was mainly that the study was powered for changes in anti-proBNP, and interpretation of secondary and exploratory endpoints should be viewed with caution. And the 8-week double-blind study duration could not limit the ability to fully assess long-term outcomes such as death, cardiac transplantation. But I think looking at the benefit we see in ambulatory patients, I think all advanced failure after stabilization during the hospital should be switched on to ARNI, or maybe given the benefit of this agent. Now the other spectrum of heart failure that we see in clinical practice is the HFpEF, that is heart failure with preserved ejection fraction, and there have been 3 studies on that, the Paramount, the Paragon heart failure, and the Parallax, which try to address that use of ARNI in these subgroup of patients. If you look at this in the Paramount, which was a phase 2 study, the anti-proBNP, I think again showed a significant difference fall as compared to Valsartan, the combination as compared to Valsartan, again emphasizing probably this combination is going to be useful in this subgroup of patient also. And Paragon study was a phase 3 study, and then again this has tried to show that there is a significant, there is a difference between, there is a better sort of a reduction of primary endpoint, but of course it was not reaching the significant level. And so there was of course significant heterogeneity in multivariate analysis by ejection fraction and sex, more benefit in women, and more benefit was seen in patients who had ejection fraction around 57%. So I think summarizing the Paragon heart failure again, it narrowly missed its primary endpoint of sort of a composite of reducing the total hospitalization and cardiovascular death. But there was a improvement trend, and there was a potential benefit of Valsartan in patient with an ejection fraction which is median around 57%, and in women as compared to men, and of safety was as similar to paradigm heart failure. And I think based on these trials, the potential benefit of LBF around 50 there is a basically biologically possible. So I think Parallax trials was also comparing the routine therapy with introduction of ARNI, again significant greater decrease in anti-proBNP levels, no significant improvement in 6-minute walk distance was seen. I think we need more trials probably to evaluate the usefulness of ARNI in patients with HFpEF issues. So, but of course, the data do support, even today the recommendation is ARNI has a 2B, sort of a class 2B indication for giving to these patients with heart failure. Of course, that there has been some concern about using ARNI in patients with severe kidney disease because that may not worsen, but I think the recommendation now recently are that the ACC has now approved ARNI for all comer heart failure patients irrespective of GFR with those adjustments. I think this is to show that even in patients with ARNI, eGFR does show improvement, and the mortality reduction is then seen even in patients with CKD class 4 or 5. So I think summarizing that, if you look at this particular molecule, it has really revolutionized our approach to treating patients with heart failure, has significantly, I think, contributed to the drug therapy for heart failure, and it should be now as a class 1A and should be used, ACE or ARB should be only used if it is not feasible to use ARNI. Of course, also in patients with advanced heart failure, I think this after stabilization, we should give the benefit of this agent. Patient with with preserved ejection fraction, again, it falls into class 2 indication. And in CKD patient, ARNI can be used with advanced CKD with advanced menopause. Thank you so much for your patience hearing. Thank you.